Thanks, Alan. Good afternoon, everyone. I am Jan Bessie. I am the team lead for RPIW number 7 in the inpatient mental health area, and our project was to reduce the lead time for social work from time of referral received to a time of service completed. And this is the agenda for our presentation this afternoon. Here's our incredible team. We have had an incredible week, and they will each introduce themselves when they come up. Here is our workshop project form. It lays out what our focus was for this week, what the current situation is, what our process flow, and makes reference to our targets. In terms of the measures that we identified to work on during this RPIW and our baseline and target, we were looking at space, social work, work in progress, walking distance, numbers of forms, length of stay, referral to service, productivity gains, rounds per day, and capacity. In terms of our calculation for Tack Time, when we looked at the various pieces, we were able to identify that given the demand for service on that unit, given that there are about 29 patients at any one time requiring services from the social worker, that translates to a Tack Time of 310 minutes. In some of the gathering of PQA data, we were able to identify, you can go ahead. We were able to identify that the prevalence of diagnosis of depression on the unit is at about 40%, and so that's the area that we decided to focus on for this RPIW. This is the current state map from the value stream for psychiatry, and that just shows you which area of the value stream map we were working in. In terms of the current state, we were trying to identify all of the cycles of work that the social workers did, and including a focus on finances and housing arrangements for patients. So our future state stream really identified trying to reduce that lead time from 30 days to 14 days, and to try and really focus in on the steps in the process. There are many strengths with social work in that area. They are very flexible to respond to patient needs, but we did identify that patients tend to dictate sometimes when they're available to meet with the social workers, and one of the opportunities that we saw was to reduce paperwork and reduce walking time and to put standard work in place. These are some of the time observation forms that were done pre-Kaizen, including which translated into the standard process. If you can just pull that down. The standard work combination sheet. And as you can see, if Sandy, if you can sort of move it up and around, there are lots of areas of sort of small bursts of activity. Here's the spaghetti diagram, and lots of travel between the basement, where the social workers' offices are, and the main floor. And this is our percent load chart, which shows that there was a fair bit of time spent in doing paperwork and a fair bit of time spent in walking and waiting.
Good afternoon. My name is Delcy Roski, and I have been a client representative on this RPIW. The idea number 1 is to decrease walking and waste time for the social workers. Because they are located on the lower level, there is a lot of walking going from downstairs to upstairs, and then finding clients. As you can see on this spaghetti map, there's a lot of tracing back and forth, and that is either looking for the clients or going from their office back to upstairs. 9,445 steps were recorded pre-Kaizen. This amount of steps that were being made by the social worker, of course, decreases the time that they can spend one-on-one with the clients. Another difficulty with their office being downstairs is that some of the clients do not have permission to go leave the unit. So therefore, the social worker has a very difficult process, and time is lost when there is online applications that need to be filled out for the client. The purpose of decreasing this walk time, of course, is a benefit and value added for all the clients that are working with the social workers.
Hi, I'm Melissa Cole, and I work with the Kaizen operations team in the medicine service line. And this week, I was a participant during this event. Up here, you'll see that we have a time observation form. So we had two very lovely social workers that we were allowed to follow for the last couple days. And from our pre-Kaizen, we noticed that we wanted to give a couple trials. So we had 2 trials of just relocating the social workers. We did some time observations, and then we also did some spaghetti maps. So the very first spaghetti map that you saw, it's tracing out how the social worker walked. So we moved the social worker's office from 0D to 1D, and the office that we chose to use at that time was the interview room. Now, the social workers still had a lot of steps that they had to take. However, originally starting at 9,445 steps a day, just that small change reduced their steps to 3,500. We then did trial number 2, and that was moving the social worker to the manager's office. So we started off with our time observations, and then we did another spaghetti just to see how many steps they were walking. Again, there was a lot of movement, but a big decrease from, again, 9,445 steps to 3,166. So an excellent improvement of just a really small change of relocating the office. And here you'll see that this is a graph that illustrates that originally pre-Kaizen, they were walking 78 minutes, and we decreased that to 38 minutes.
Good afternoon. My name is Dev Francis. I'm a clinical coordinator or charge nurse on inpatient mental health. Part of my Kaizen role was to, we were doing the doctor's rounds. Traditionally that happens twice a week, Wednesdays and Thursdays. They usually start at 9 o'clock, lasting till 11 o'clock. Sometimes they go longer than that. One of the reasons why, it's a multidisciplinary team. We have social workers, we have people from the mental health clinic, we have addiction services, we have pharmacists, doctors, residents. One of the reasons why it does go longer than 2 hours is we spend a lot of time waiting. Those waitings are waiting for doctors, we're waiting for charts, we're waiting for a variety of different things. The doctors have appeals, they have family meetings. They're very busy, so we had a lot of time waiting. The room that we had the rounds in was off the dining room in one of the TV rooms. Very busy, very transparent, not a whole lot of privacy. The rounds that we discussed were, the patients we discussed on rounds were depending on which doctor showed up. So post-Kaizen, we decided to try rounds Monday to Friday from 9 o'clock till 9:30. That gives the doctors opportunities. If they can't make it on their Wednesday or Thursday day, they can come in Monday to Friday with a target of 30 minutes. Instead of meeting in the TV room, we were going to meet in one of the back rooms on East or West. So there's no setup time. It's more private. The tables and chairs are already there. With the help of IT, we have a teleconference, so people from the mental health clinic and people from ADS can stay in their office and we can teleconference. They have direct access to their computers. As you all know, parking at both sites is brutal, so if they can stay there, it's awesome. So it eliminates travel time for them. and increased communication for all team members. The other thing we did was we developed a stamp for home care for the physicians. So when patients are discharged to home care, we can just stamp their chart, and the doctor can write on there how often they want home care to follow these patients. So it was an awesome experience, and it's a work in progress, and I'm sure it'll work. Thank you.
Good afternoon. My name is Janet Eberly. I'm a nurse on adult inpatient psychiatry. Kaizen idea number 3 was to create a standard work for identification of community rehab or other workers for community of care for patients. Pre-Kaizen, there was no way to identify if the patient had any involvement with any community mental health workers prior to admission. Post-Kaizen, with the assistance of the Mental Health and Addiction Services Liaison and IT, the unit secretaries, social workers, and charge nurses are now able to enter the CIS and find this information. There was a column entered on the care plan to write the community worker's name. This system also allows the unit to determine which, if any, psychiatrist is involved with the patient's care. The access to the CIS was found to be very helpful on the unit. Kaizen number 4 was to create a standard work for identification of date of referral for social work services. Pre-Kaizen, there was no way of identifying the date a referral was made to social work. Therefore, it could not be determined if the referral was completed in the targeted 3 days. Post-Kaizen, we entered a column on the care plan to highlight the date the referral was made and initials of the person processing the referral. Pre-Kaizen, dated referrals were at 39%. Post-Kaizen, dated referrals were at 100%.
Hi, I'm Sandy Eitnayer, and I'm the sub-lead on this RPIW, and I'm presenting the idea number 5, and that's the automation of forms used by the social worker to reduce cycle time. Pre-Kaizen, we discovered that she had a lot of paperwork. It wasn't always, the forms weren't always available, and some of the forms just didn't work. There was one form that was on the computer for them, and there was no flow to it. By the time they got to the bottom line, they would have to start another form and do the demographics again and proceed. So one charting episode could have 3 different forms. And the justice form that they use a lot did not have adequate space. So post-Kaizen, IT did some really great work for us. They fixed the form, so the form that didn't flow through, it now flows through and it just continues on. The justice form, they're still working on it, but that's got them very excited. And the other thing is that we did, that pre-Kaizen, we followed one social worker all the way to the other end of the hospital to get a form that she needed. So what we did, we scanned a lot of the forms into the computers for all 3 social work, and they can print them. It is our hope that we can get them computerized so they can actually print on them. So that was a reduction of 31% of the time spent on paperwork. Idea number 6 was to do standard work for social work for a patient with diagnosis of depression who requires assistance with financial and housing arrangements. We discovered pre-Kaizen that there was no standard work, and there was duplication occurring between the social worker on the inpatient unit and the community social worker, and that there was unequal workload and no standardized time of referral to the social worker. In some instances, the social worker was not being referred to until several days after the targeted date of discharge. Post-Kaizen, one of the things we did, we gave the unit clerks and charge nurses access to a CIS database, and that identified who had community workers. So at that time, IT made a column for us so that we flagged with a little green dot who had a community worker. And then we did a second column, and it was the barriers to discharge. And there was standard work done on that so that we could use common barriers. And the last column was, for the time that the referral was made to social work and the time that the social work service was complete. That's not yet done, but it's to be added soon. Thank you.
Hi there, I'm Jackie Fichter, patient representative. Pre-Kaizen, our 5S evaluation score was a 1.2. Mini 5S in social worker's office. There's the overflowing bookshelf and overflowing file cabinet, as you can see in the back there. Approximately took about 2.5 hours to complete the initial 5S. But the experience gives me a motivation to attempt a similar activity at home.
Hi again. So post-Kaizen, or post-5S, I should say, we scored a 2.8, and we're actively working towards a 5. It'll take us some time. The file cabinet that you just saw, we were able to completely remove all of the items in that cabinet. Everything had been outdated, expired resources, so we just eliminated all of it. The next was the bookshelf, and we were actually able to completely eliminate the bookshelf as well. We donated it to another area that needed it, so we got rid of all of those resources. And we were able to really create a much more open space. So now in this environment, it's truly what you need to do your job when you need to do it. And that was an increase, I believe, of 15% just overall space. When we removed all the items, we were able to donate the majority of the items. The only thing that we actually trashed were the 8,000 pieces of paper that were outdated in the file cabinets. And the overall removal, I think it was $1,805 that the region will now save without having to put back in, because we were able to donate and recycle all of those items.
Just to summarize our workshop, the target progress report and results sheet, we were able to achieve a 15% change in the space in the social worker's office. We were not able to make a difference with respect to the workers, social workers' work in progress. In terms of walking steps, we were able to make a 63% improvement by reducing their steps. In terms of the pages, our target was to reduce by 50%, and we were able to eliminate 57 pages. So that was a very good result. We, because of the length of the RPIW, we're not able to know whether we've affected the lengths of stay at this point, but we think that there are some good potential to do so. Quality defects, we wanted to make sure that social work referrals were made within 3 days, and we've achieved that with this RPIW. Productivity gain, no change. The 5S score was a 32% improvement. The rounds score, we improved efficiency by decreasing the time spent by 25%, and we believe in terms of the cycle time that that we can anticipate a 20% improvement. This is a form that shows productivity reinvestment and potential for the region to be able to redirect about $75,000 a year with the changes that we've made. This is a conservative estimate. Our post-Kaizen percent load chart just shows that we've been able to make some reductions in some of the paperwork time and the wait time. Many of the items on our newspaper are about 75% completed. There are some 100% completes, but we'll continue to have to work on a couple of things. So in terms of the workshop summary, We've had a successful trial of decreased walking time by moving the office to the unit, creation of standard work for rounds, establishing links to CIS, standard work for identification of date of referral, and creation of additional space. Thank you to our sponsors, our process owners, the staff on inpatient mental health, IT, Nancy, our KPO support, Sensei Shuno and Ritsuko, and especially our patient representatives. Thank you.